Guys, welcome back on our channel MedStudent Help. This is our fifth video in the pharmacology of the cardiovascular system. In this video, we're going to be covering the congestive heart failure drugs. I hope this way you can see the whiteboard much better. So we're going to try it out this time and see whether this is going to be better or not. So it would be good if you guys could leave your reviews about this video comparing to the previous ones. So let's get started with the basic physiology of the heart function. So we know that the heart actually depends on three things to proper function. It depends on the preload, which is basically the end diastolic volume. It's how much volume has reached the heart before contracting. And it also depends on the afterload. How much pressure is in the vessels that is going to be meeting the blood that is ejected from the heart. This is the afterload. So the afterload is always determined with the total peripheral resistance, which is determined by how much contraction is in the arterioles. The third thing that the heart function depends on is the contractility. So as we know that the heart is a muscle. It is a cardiac muscle, right? And this muscle is in continuous need of oxygen, ATP, glucose, and calcium, the intracellular calcium. So these things, if they are available for the cardiac muscle, then the cardiac muscle is going to be contracting well, and it is going to be ejecting the blood out of the heart. Now, in this figure, or in this drawing, so here you see the right ventricle and the left ventricle. So we know that the blood, after circulating in the right ventricle, is going to be pumped out towards the lungs and come back from the lungs to the left atria, then to the left ventricle, right? And the left ventricle has to pump the blood outside to the peripheral tissues from the brain to the toes, right? So all the peripheral tissues should be perfused well as a function of the left ventricle. Okay, now, so let's imagine that this person has had a congestive heart failure. What does this mean? It means that the heart pumping function is reduced. It is not pumping as well as it's supposed to be. And due to that, there is going to be a backward failure. Now, in most of the cases of the heart failure, it would be both ventricles affected. Yes, there are a couple of cases in which there can be, for example, a right ventricular isolated failure or left ventricular isolated failure, right? But in this case, we're talking about the more frequent, which is the heart failure that includes both ventricles. Now, if the right ventricle wasn't functioning well, wasn't functioning properly, this means that the blood is going to accumulate backward. And this is going to lead to the distension of the carotid vein, for example. So you would see it in the neck of the patient that there is a carotid distension, right? Because the blood isn't being ejected from the right ventricle, so it is building up from the right ventricle backward to the carotid area, right? It is building up, okay? Now, and it is going to also build up in the inferior vena cava too. And the inferior vena cava was drawing the blood back from for example, the liver, from the spleen, from all the organs of the abdomen, right? So this is going to lead to a hepatosplenomegaly. So the patient is going to continuously feel discomfort and abdominal pain and, complains about his defecation and stuff like that, okay? This is the second symptom of the backward failure of the right ventricle. Also, the fluid is going to build up in the extremities, right? And this is going to lead to the peripheral bilateral. This is very important to notice that it is bilateral edema, right? So peripheral bilateral edema is going to develop, and it is the pitting type, as you remember from pathophysiology. Okay. Now, let's see what happens when the left ventricle isn't functioning well. Now, we know that the left ventricle was receiving the blood back from the lungs, right? To the left atria, to the left ventricle. So, if the left ventricle wasn't pumping the blood well outside of it, this means that the blood is going to accumulate in the left ventricle, is going to accumulate in the left atria, which means that it is going to accumulate in the lungs. And this is going to lead to congestion in the lungs. It may lead to edema in the lungs. And as a symptom of this, what is going to develop is dyspnea. So the patient is gonna find it really, really difficult to take a deep breath. Okay, so the left ventricle isn't functioning well. Okay, what about the stroke volume? Now, the stroke volume, right? Okay, sorry for this, I'm just not used to use it. Okay, so the stroke volume, we know that the stroke volume is basically how much blood is ejected from the left ventricle. Now, if the left ventricle wasn't pumping the blood out well, this means that the stroke volume is going to decrease. And this also means that the total cardiac output is going to decrease too. So what is going to happen to the perfusion of the peripheral organs? It's definitely going to decrease, right? So the pump function of the heart is decreased. The perfusion of the peripheral tissues is going to be decreased too. Okay, so let's see what would the brain do when the perfusion is decreased. The brain is going to get so upset about decrease in the perfusion. And when it's upset, it is stressed. So what does a stressed brain mean? That it is going to activate the sympathetic nervous system. So the CNS, the central nervous system, is going to lead to the activation of the sympathetic nervous system. And as a function of the sympathetic nervous system, there is going to be vasoconstriction on the vessels. Now, if there was a vasoconstriction, what will happen? There is going to be an increase in the total peripheral resistance, right? There is going to be an increase in the total peripheral resistance, which means that the afterload is going to increase too. If the afterload is increasing on a failing heart, this is going to make things worse. Also, the sympathetic nervous system is going to lead to increase in the heart rate, right? So there is going to be a tachycardia, and the heart isn't even functioning well, and the diastolic volume wasn't even that good, or it was actually building in the heart, and with accelerating the heart rate, well, the function of the heart is going to definitely will go even worse on the long run. Okay, so the sympathetic nervous system may help acutely with the symptoms, but on the long run, it is going to lead to deterioration of the case here, since the afterload is going to increase, right? Now, the sympathetic nervous system has also connection with the kidney at the beta-1 receptor. Now, if you have watched the calcium channel blocker video, we have explained there that we have juxtaglomerular cells, right? And we said that these guys own a beta-1 adrenergic receptor. So whenever there is an activation of the sympathetic nervous system, there is going to be activation of this receptor, which is going to eventually lead to the release of the renin, right? This is going to lead to the release of the renin. And if we release the renin is going to lead to the activation of the Renin-Angiotensin-Aldosterone System. Now, what does the system do? We know that this system is going to end up forming the angiotensin II, and it is going to lead to the vasoconstriction. And it is going to lead to the release of the aldosterone, and we know that the aldosterone is going to lead to the retention of the water and the salts and increase the volume. Now, absolutely, now you've noticed that increase in the vasoconstriction means that there is going to be increase in the total peripheral resistance again, which means that there is increase in the afterload again, which means that on the long run, the heart is going to be suffering again, right? And increase in the volume due to the retention of the water and the salts by the function of the aldosterone that has been released as a response to the Renin-Angiotensin-Aldosterone System. This is going to increase the volume. Now, do we need to increase the volume in this case? Is the volume our problem? No. The pumping function of the heart is our problem. So the volume is going to further increase the preload, and it is going to even make things even worse on the heart, right? Because now there is even more volume for the heart to pump out. Okay? Now, also the perfusion of the kidneys is going to be decreased, right? Because the left ventricle isn't pumping well, so the perfusion to the kidney is going to decrease as well. Now, if the perfusion to the kidney is decreasing, this means that the glomerular filtration rate is going to decrease. And if you have watched the RAS system drugs video, I've mentioned there that the juxtaglomerular cells are clever cells. They can sense the pressure in the afferent arteriole. Now, if the pressure is dropping in the afferent arteriole, these cells are going to release the renin. And the renin is going to again activate the Renin-Angiotensin-Aldosterone System, and it is going to end up with vasoconstriction, increasing the afterload, and increasing the volume, increasing the preload. Okay. Now, so when you think about it, a patient came with symptoms of heart failure. What should we do? Should we act on increasing the pumping function of the heart, or shall we stop these compensatory mechanisms? Absolutely, we should stop the compensatory mechanisms. Why? Because the compensatory mechanisms are making things worse. So maybe if we stop the compensatory mechanisms, which are the sympathetic nervous system and the RAS system, if we stop these guys, maybe the heart is going to have the chance again to function well, right? Now, let's get started with the sympathetic nervous system. How can we stop this compensatory mechanism? Of course, it is easy to use the beta blockers. Always a first-line drug for the heart failure is the beta blocker, right? Now, so the beta blocker is going to stop the vasoconstriction, it is going to stop the tachycardia, it is going to stop the activation here of the beta-1 receptors on the juxtaglomerular cells, okay? Now, the second thing is to stop the RAS system. How can we stop the RAS system? We can inhibit the angiotensin converting enzyme. We can use the ACE, so the angiotensin converting enzyme inhibitors. We know that this enzyme was responsible for converting the angiotensin 1 to the angiotensin 2. And we know that the angiotensin 2 was the active form that is going to lead to the vasoconstriction, and it is going to activate the aldosterone release. So we may just stop the whole process by giving angiotensin converting enzyme inhibitor. Now, we know that in some patients, if we give them the ACE inhibitor, they may develop coughing. They may develop angioedema. And we've mentioned if the patient developed these, you have to stop the drug. So if we stop the drug, what can we give instead? We can give the ARB, which is the angiotensin receptor blocker. If you didn't watch this video, go back and watch it and get to know these guys much better than this short explanation. Okay, now, so I've mentioned that also the Renin-Angiotensin-Aldosterone system is going to lead to increase in the volume because of the aldosterone. So can we stop the aldosterone? Yes, we can stop the aldosterone. If you didn't watch the diuretics, go back and watch it. This is going to be the aldosterone receptor antagonist. These guys belong to the diuretics, right? Now, and to decrease this volume that is increasing here, we can give diuretics as well. So we may decrease the preload and also decrease the afterload if we give diuretics. Why? So diuretics are going to decrease the end diastolic volume, which is going to decrease the preload. And it is going to decrease the volume, which means that the blood pressure is going to also decrease. If the blood pressure drops, the total peripheral resistance is going to drop too, and the afterload is going to drop too. So the diuretics are going to decrease both the preload and the afterload. Now, the fifth thing that we can use here is the cardiac nitrates. The cardiac nitrates, we have explained them in the anti-anginal drugs, and we said that these guys in low dose are going to lead to venodilation, dilation of the veins. And we know that the veins are the storage room of the blood, right? So if we dilate this storage room, we're going to decrease the preload on the heart and we're going to help the heart function better, right? And if we increase the dose of the cardiac nitrates, we're going to also do arteriolodilation. So we're going to decrease the total peripheral resistance and the afterload. Okay? So as a conclusion, always before using any ionotropic drugs, we should apply beta blockers, and these are the guys here: metoprolol, atenolol, bisoprolol, betaxolol, nebivolol, ciliprolol, anyone. And we should use ACE inhibitors and ARBs. So the ACE inhibitors, the captopril, lisinopril, enalapril, ramipril, and benazepril. And the angiotensin receptor blockers were the losartan, valsartan, telmisartan, candesartan, irbesartan, and iprosartan. And then the diuretics. Here we mentioned the aldosterone receptor antagonist, which is the spironolactone. It is very commonly used in the heart failure patient to give spironolactone. What was the side effect of the spironolactone? A very important side effect in males. We said that it is going to lead to enlargement of the breast, right? So the gynecomastia, the spironolactone, because it is not selective to the aldosterone receptors, but it is going to block any mineralocorticoid receptor. And we mentioned that the spironolactone belongs to the aldosterone receptor antagonist, which is a potassium sparing. We can't give a potassium sparing diuretic alone. We should always combine it with loop diuretic or thiazides, right? So we may give a spironolactone with a furosemide or any of the thiazides. Okay? And the last thing that we mentioned here was the cardiac nitrates, so the drugs that we use against angina, and this was the nitroglycerin that we may give sublingually in case of the acute case. So the patient develops sudden chest pain, give nitroglycerin beneath the tongue, right? It is a spray beneath the tongue. And we may apply it as a transdermal patch too. The other choice would be the isosorbate dinitrate or mononitrate. Okay, now so let's say that we have given these drugs to the patient didn't improve, the patient is still deteriorating, and he's reaching an end-stage heart failure. What can we do right now? We have the last choice to save this patient, which is to increase the contractility. So this is going to be our last thing to think about in case of the heart failure. We may increase the contractility. What does the increasing the contractility mean? It means using drugs that are going to have positive ionotropic effect. What are these drugs? We have the digoxin, digitoxin, deslanoside, and the Ouabain. In this stage heart failure, we would actually like to increase the contractility of the heart, and this is, in another word, is the positive ionotropy, right? So what drugs can be used in order to enhance the ionotropy of the heart or the contractility of the heart? We mentioned the cardiac glycosides already, but we have also three other categories. These are going to be the beta-1 receptor agonists and the phosphodiesterase inhibitors, and the last category is the calcium sensitizers. Now let's get started with the cardiac glycosides. So I mentioned already the examples that we have in the cardiac glycosides: the digoxin, digitoxin, deslanoside, and the Ouabain. Mostly used the digoxin, digitoxin. Okay, now what is the structure of all of these guys, of all the cardiac glycoside? The structure is a glycan. Now, what do we mean with a glycan? A glycan is a steroid and a lactone. Okay, I got it here. So this is the structure of all the cardiac glycoside. It has a steroid part right here, and it has here, this is the lactone ring. Now together, the lactone ring and the steroid part is a glycan. Now, when we add a sugar part into the steroid, this is going to become a glycan, right? So sugar plus the aglycone part, which is made of the steroid rings and the lacton ring, is going to give us the glycone. So the whole thing is called the glycone. This is the cardiac glycoside chemical structure. Now, we know that on the steroid rings there would be hydroxyl groups. Okay, now if you see it here, this is a hydroxyl group on the steroid rings. Now the different drugs, the Digoxin, Digitoxin, Deslanoside, and Ouabain, they have different number of the hydroxyl groups. So in Digitoxin we would find only 2 hydroxyl groups, but in Digoxin 3, in Ouabain 6. Now let's see what difference would that make if they have more or less hydroxyl groups. Now we know that the hydroxyl group is going to increase the water solubility, which means hydrophilicity. Okay? Now, so out of these 3, the Ouabain is going to be the most hydrophilic, and the Digitoxin is going to be the most lipophilic, the most lipid soluble drug out of these, because it has the least hydroxyl groups. Okay. Now, what difference is going to be on the plasma protein binding? Now, we know that if the drug is more lipophilic, it means that it would need more proteins to bind to them in the plasma. So the Digitoxin is the most lipophilic, meaning that it will have higher plasma protein binding than all of the others. This is a very important thing that we're going to get back into it when we talk about the pharmacokinetics of these drugs. Okay, now let's see, how do the cardiac glycosides actually work? How do they function? Now, we know that in all of the cells in our bodies, including a cardiac muscle, so this cell is a cardiac muscle, they have a sodium-potassium ATPase. Okay, so this transporter that you already know, pumping sodium outside and potassium inside. And as you know from the basics that the sodium concentration is high outside, right? It is always high outside the cell. So here there would be a lot, there would be a lot of sodium inside, outside the cell, right? Comparing to inside. So sodium concentration is high in the outside, in the extracellular area, okay? And the potassium is high inside. Now, we know that due to the low concentration of the sodium inside the cell, there can be a positive concentration gradient. So this is a passive, not positive. This is a passive sodium concentration gradient towards the cytoplasm. We can use this gradient to pump calcium outside of the cell. Now, let's remember, what did we need for the muscle contractility, right? We know that for the contraction of the muscle, we need oxygen, we need glucose, we need ATP, and we need calcium, right? So, which of these can be controlled in order to increase the contractility? Can we target the oxygen? Can we just start increasing the oxygen perfusion to the tissues? Well, not really. Neither the glucose or the ATP. We can't control, and let's say, okay, so let's start increasing the glucose supply to the heart. How can we do that? There's no way to do that. So we can increase the intracellular calcium. This is the only way we have to increase the contractility of the muscle. Now, so in the normal situation, in a cardiac muscle, the sodium-potassium ATPase would be functioning here, creating the sodium concentration gradient towards the cytoplasm, and the calcium would be pumped out, meaning that with time the concentration of the calcium is continuously decreasing inside the muscle. This is the physiological situation. Now, when we give the cardiac glycosides, what we're gonna do is that we're gonna block this transporter. We're gonna totally stop it. How? These digoxins and digitoxins are going to bind into the potassium binding site in this transporter and totally block it. So here's what's going to happen. We blocked the transporter. This means that there is no any sodium outflux anymore, and the sodium is going to accumulate inside the cell, right? Which actually means that the inward sodium concentration gradient is also cancelled, since the concentration of the sodium inside the cell has increased. And this means that the calcium is not going to be pumped outside of the cell anymore. So the conclusion is that whenever we're giving these cardiac glycosides and blocking these transporters, we're ending up with increasing the calcium concentration inside the cell. Now, the increase in the intracellular calcium here, this is going to activate the ryanodine receptors on the sarcoplasmic reticulum. I've already mentioned that in the calcium channel blocker video, but anyway, it's not important to go back to it if you don't need to. So whenever the calcium concentration is increasing in the cytoplasm, it is going to lead to the activation of the ryanodine receptors that are present on the sarcoplasmic reticulum. And as you know, the sarcoplasmic reticulum are the calcium storage rooms of the cells. So the sarcoplasmic reticulum is going to start releasing more calcium into the cytoplasm. So we have now two ways to increase the calcium in the cytoplasm. The first one was by cancelling this outward movement of the calcium, and the other one that the sarcoplasmic reticulum is going to start releasing the calcium to the cytoplasm. So now we have increased calcium. This is going to increase the contractility, which means positive ionotropy, right? This is the main function. But what does the cardiac glycosides do as well? So we said positive ionotropy, increasing the contraction. Now, by increasing the contraction, we're going to enhance the circulation, right? So this is going to decrease the stasis that was already present in the heart failure patients, and the perfusion or the kidney blood flow is going to increase. And as we know, if we increase the kidney blood flow, first of all, we're going to inhibit the RAS system because the pressure in the afferent arterioles is going to be increasing. So there is no need for the RAS system anymore. We're going to stop it. And as you know, that the more blood arriving to the kidney, the more urination. So more diuresis. If you urinate more, the blood volume is going to decrease, or the plasma volume is going to decrease. And this means that we are decreasing the stasis and decreasing the edema. Okay, what other functions or what other effects do the cardiac glycosides have? They have a positive bathmotropy. What does bathmotropy mean? It is the excitability. So as you see, that it is not only the calcium that has increased in the cells, but it is also the sodium. And this may lead to increase the excitability of the cardiac muscles, that it can lead to arrhythmia. So extrasystole can develop, ectopic rhythm can develop. So there is always a risk of arrhythmia when we are treating a patient with cardiac glycoside. So as you can notice that this is going to be a side effect. Okay. Now, there is going to be also a negative chronotropy as well as a negative dromotropy. What does this mean and how did this happen? Negative chronotropy means that there is going to be decrease in the heart rate. And negative dromotropy, it means that there is going to be a negative effect on the conduction, decreasing the AV conduction. How did this happen? So as we said, that the sodium-potassium ATPase is not only present in the cardiac muscles, so the cardiac glycosides aren't that selective to the cardiac muscles. They are going to act on the other tissues that have this transporter as well. And one of these tissues is basically the nerves. Now, in the brain, in the vagus nucleus, these drugs are going to act on the vagus nerve, and they are going to enhance the calcium concentration in the cytoplasm of the vagus nerve. Now, if you remember from the calcium channel blocker video, I mentioned there also that the calcium is really important for the nerves to release their neurotransmitters. Now, if we increase the calcium in the vagus nerve, this means that the acetylcholine release from the vagus nerve is going to increase. And this is translated as increasing the vagal tone. Now, this increasing vagal tone is going to lead to decrease in the heart rate, and it is going to decrease the conduction, leading to decrease in the AV conduction, right? So the atrioventricular node conduction. Now, why didn't the vagal tone lead to negative ionotropy? How comes it just decreased the heart rate without decreasing the contractility? Because if you remember from anatomy that this vagus nerve, it doesn't really innervate the ventricles. It only innervates the atria. So the atria, where the sinoatrial node and the AV node are, these are going to be affected by the increasing vagal tone. But the ventricles are not going to be affected, and there is going to be still positive inotropy and positive bathmotropy going on, right? Okay, let's imagine that a patient has taken, by mistake, a high dose of these cardiac glycosides. There's going to be a huge negative chronotropy, right? So there is going to be a bradycardia. How can we stop this bradycardia as an effect of the toxicity of these cardiac glycosides? How can we stop it? We can stop it by basically reversing the function of the vagus nerve. How can we do that? We can use the atropine. We know that the atropine is a muscarinic receptor blocker, right? So we just block the receptors. The acetylcholine that is released from the vagus nerve is not going to function anymore on the muscarinic receptors because they are going to be blocked by atropine. Okay, now the cardiac glycosides are going to also function directly on the kidney and decrease the renin system. And as we said, that the RAS system, this compensatory mechanism, was harmful on the long run, right? So decreasing the renin release is totally beneficial here. Okay, what is the pharmacokinetics of the cardiac glycosides? These drugs most likely are given orally, although we can give them IV in case of the acute cases. Now, when we give them orally, the plasma protein binding is going to be 97% for the digitoxin, whilst it's going to be only 60% to digoxin. Why is that? Because we said here that digitoxin has only 2 hydroxylic groups, while digoxin has 3. So digoxin is more hydrophilic. It can swim more in the serum, right? Comparing to digitoxin, that it would need more carriers in the plasma. And that's why digitoxin has 97% plasma protein binding comparing to digoxin having only 60%. Okay, now what other differences is going to be relating to that? The digoxin is going to be eliminated mostly unchanged to the urine. So you can think of digoxin that it is always with water. So we know that water is going to be eliminated in the urine, right? It just swims to the kidney, then from the kidney, it is going to be eliminated out as urine. Digoxin is going to be swimming there. Most of it is going to be just excreted unchanged in the urine. What about digitoxin? Now, digitoxin is different. For the elimination of the digitoxin, it is going to be metabolized in the liver. Now, when it is metabolized in the liver, it is going to be sent to the gallbladder. So the bile then is going to reach into the intestine, as you know, and there is going to be a risk of accumulation. Now, why is that? The digitoxin, when it's metabolized in the liver, it is going to be by conjugation with the glucuronide. So it is a process called the glucuronidation. Okay? Now, the glucuroninated, the glucuronine, what is it? It was the glucuronide, okay? So glucuronide conjugation of the digitoxin in the liver is going to be sent to the bile. It is going to reach the intestine. Now, in the intestine, we have bacteria, right? These bacteria are able to cleave the glucuronide that was bound to the digitoxin. So if we cleave the glucuronide from the digitoxin, what is left is digitoxin alone. It's like the active form of the drug again, right? So it is going to be reabsorbed from the intestine, and this is the so-called the enterohepatic recirculation of the digitoxin. And that's why digitoxin use should be much more carefully administered than digoxin, because Digitoxin carries a risk of accumulation because of the enterohepatic recirculation. Okay, now the half-life of digoxin is 36 hours only, comparing to 4 to 5 days for digitoxin. Why is that? We just mentioned. It's because it is going to be cleaved again, and digitoxin is going to be formed again in the intestine and reabsorbed, enterohepatic recirculation. So it would need 4 to 5 days to be eliminated totally from the body. Not totally, half of it. So half-life, right? Now, the LD, it means the loading dose. It means the first dose that you are giving, okay? Now, the loading dose of the digoxin is going to be 1.8, while the digitoxin 1.2 milligrams. And then we have the maintenance dose is going to be 0.5 milligram per day for digoxin, whilst only 0.1 milligram per day for digitoxin. So you can think of it that digoxin is a little bit weaker than the digitoxin, or it is a little bit less potent than that of the digitoxin. Okay, now let's see what toxicity do the cardiac glycosides carry. Now we said that accumulation of the digitoxin carries a huge risk of toxicity, right? But it is not only digitoxin that is toxic. Actually, all of them are toxic. Digoxin, digitoxin, Deslanoside, Ouabain, all the cardiac glycosides are toxic. Because if we think about it, they may function more than needed. And if they functioned more than needed, there is going to be a huge decrease in the heart rate, leading to bradycardia. They may lead to an excessive decrease of the conduction at the AV node. They can lead to slow AV conduction and maybe block as well. And they can lead to ventricular extrasystole, and that's the positive bathmotropy, the arrhythmia. Okay? So ventricular extrasystole and even ventricular fibrillation. And as you know, that ventricular fibrillation is lethal. And so it is a very, very serious side effects can develop in case of the not so monitored cardiac glycosides. Now, away from the heart, cardiac glycosides can cause side effects on the CNS and on the GIT. Now, on the CNS, it is going to lead to headache, dizziness, convulsions, and hallucinations can also develop. Now, what about the GIT and why does this happen? So we said that the vagal tone is going to be increased. But is the vagal tone is going to be increased only on the heart? Of course not. Because if you increase the vagus nerve activity, it is going to increase on all the tissues, right? And one of the tissues that are innervated by the vagus nerve is the GIT tract, right? So this is going to lead to nausea, vomiting, and diarrhea because there is going to be increase in the motility along the, this peristaltic movement is going to be increased and diarrhea may develop. Okay, now when do the cardiac glycosides become toxic? Is it like whenever we're treating the patients with cardiac glycosides, are they always toxic? Well, not really. But if the cardiac glycosides were given in an overdose, or if the plasma concentration of the potassium is low, then there is a high risk of toxicity. Okay, let's see why would this happen. So, as you remember here, we said that the cardiac glycosides are going to inhibit this transporter by binding to the potassium binding site. Okay? Now, if there was already low concentration of potassium in this patient's body, this means that there is not going to be so much competition between the potassium and the cardiac glycosides. And clearly, the cardiac glycosides are gonna win in this fight, and they are gonna block a lot of sodium-potassium ATPases, and this is gonna be carrying a huge risk of toxicity if there was low plasma potassium. Now, if there is an increase in the calcium concentration, why? Because we said that the drug is gonna be increasing the calcium inside the cell. What if the patient had already a very high calcium in his plasma? Then this effect might be doubled and it is going to carry a risk of toxicity. And the last one is renal failure. So if the patient had a malfunctioning kidney, this means that the elimination of the digoxin is going to be decreased and the digoxin is going to accumulate in the body and is going to end up with toxicity, right? Now, let's see the interactions. Okay, so the wow, why is that not zooming? Okay, anyway, so the interactions that are going to happen with the cardiac glycosides. You can't give the cardiac glycosides to a patient who's receiving verapamil, which was a calcium channel blocker, amiodarone, propafenone, and the quinidine. All of these three are antiarrhythmic drugs. Maybe you're not familiar with it yet, but you will soon. So you can't actually give these drugs together with digoxin or digitoxin or any cardiac glycosides. Now let's think about it. Why can't we give them together? Now, verapamil and digoxin, they are both transported across the membranes of the cell by a transporter called MDR, the multi-drug resistant. Okay, it is the MDR transporter is the transporter that is going to be carrying both verapamil and digoxin. This transporter is present in the kidney, and it is responsible for the elimination of digoxin and the elimination of verapamil. If you give these two drugs together to the patient, then there is going to be a huge competition between these drugs on the MDR, and the verapamil is going to win this competition. If the verapamil wins the competition, this means the digoxin is going to be accumulating in the body because the verapamil is occupying the MDR. And if the digoxin is accumulating, this is going to lead to toxicity, right? Now, also, the patient who's taking a drug that can lead to hypokalemia. Now, you know, for example, if the patient was taking loop diuretics alone, they may lead to hypokalemia, and this can lead to increase in the risk of the toxicity of the cardiac glycosides. Or if the patient was taking a calcium supplement, okay, this might be an interaction too, because we don't want a huge effect of the drug if the patient was taking calcium supplements, okay? Now, or maybe thiazides. As you know that thiazides, they increase the calcium concentration, they increase the calcium absorption. So we might not give a patient cardiac glycosides if they are taking thiazide diuretics too. Now, the indication of the cardiac glycosides. When do we give the cardiac glycosides? So as I mentioned, is in the stage heart failure. If the patient has been given all the previous drugs that we discussed, the beta blockers, the ACE inhibitors, the diuretics, and they are still symptomatic, then we have nothing else to do other than using the cardiac glycosides to save the patient. Okay, just one thing that I skipped here. If the cardiac glycosides have developed toxicity, what can we do? We can, first of all, or we have to stop the drug administration, and then we can give anti-digoxin antibodies. We can give potassium administration with ECG, because always, like, if you're giving the patient potassium, there is going to be a risk of arrhythmia, so you should administer potassium with ECG monitoring. And we may block the vagus nerve that might be causing the bradycardia and stuff by atropine, as I discussed already. Anyway, let's see the contraindication of the cardiac glycosides. What patients can't be given cardiac glycosides? If the patient had a sinus bradycardia, or a slow AV conduction, or hypertrophic cardiomyopathy, WPW syndrome, the Wolff-Parkinson-White or White-Parkinson-Wolff, I don't really remember what exactly was it, but the WPW syndrome and the ventricular extrasystole, the previous acute myocardial infarction, and the renal failure. Now let's see this drawing. I tried to make it a little bit easier to memorize all of these. So one is the sinus bradycardia, because we know that these drugs are going to decrease, they are going to decrease the heart rate by the increasing vagus tone, right? So if the patient had already a sinus bradycardia, you shouldn't give cardiac glycosides because the heart rate is going to drop even more. A slow AV node, okay, So if the AV conduction was already slow, you can't give cardiac glycosides and make it even slower, right? Hypertrophic cardiomyopathy. So the hypertrophic cardiomyopathy, usually there is this thickening in the interventricular septum. So basically the filling of the ventricles is going to be disturbed, and usually in the hypertrophic cardiomyopathies, we shouldn't increase the ionotropy, but maybe we should decrease it. So the filling would be better. WPW syndrome, it would have this conducting fibers that are causing the problem, and in this case we shouldn't give it because we said that it is already causing a risk of arrhythmia, and with these patients the risk of arrhythmia is going to be even higher. Now, a previous acute myocardial infarction, so I tried to make this as a scar tissue, okay, so number 5 here. And why wouldn't we give a cardiac glycoside to a patient who had a previous acute myocardial infarction? So the acute myocardial infarction is going to leave a scar, okay? If you're increasing the contractility of the wall of the heart here by the positive inotropic effect of the cardiac glycoside, this scar may rupture, right? And if it ruptured, the patient may die within minutes, okay? So you shouldn't give it to a patient who had acute myocardial infarction before. And the renal failure, so this is, well, this is a kidney, okay? Yeah, so we shouldn't give it because the drug needs to be eliminated to the urine, and if the kidney is not functioning, this is going to lead to the accumulation. Okay, let's move to our second category, the beta-1 receptor agonists. Besides, our second category is going to be the beta-1 receptor agonists. Now, as you know that the beta-1 receptor, which is an adrenergic receptor, it is a G protein coupled type from the stimulatory type. So these three circles would be the alpha, beta, and gamma. These proteins are going to be attached into the beta receptor. And when the ligand, which is going to be the beta-1 receptor agonist, one of these drugs, binds here, this receptor is going to be activated, and it is going to lead to the activation of the adenylate cyclase. And as you remember, the adenylate cyclase converts the ATP into cyclic AMP. Now, this is the cardiac muscle, just to be clear. Now, the cyclic AMP is going to lead to the activation of the pKa, which is the protein kinase A. This protein is going to phosphorylate two things. The first thing that it is going to phosphorylate is the L-type voltage-gated calcium channel. Now, as you see here, I've drawn a phosphate group attached into the calcium channel, and there is a little small plus next to it, which means that the phosphorylation of the calcium channel is going to lead to the activation of it. Okay, so the permeability of the calcium is going to increase. So the calcium is going to get into the cell when the calcium channel is phosphorylated, okay? Now, the other thing that is going to be phosphorylated as a function of the protein kinase A is this calcium ATPase that is present in the sarcoplasmic reticulum. So as you remember, when I mentioned the types of the calcium channels, I mentioned that we have a calcium ATPase, which is responsible to pump the calcium back into the into the sarcoplasmic reticulum, right? So this would be pumping the calcium inside, okay? Now, if we blocked this transporter, then the calcium is going to be accumulating in the cytoplasm. If you want to know the other name of the transporter, it is the so-called the phospholambin, okay? It is, okay, let me write this down. It is the phospholambin. Okay, so the phospholambane, right? Okay, just in case you want to know it. So this calcium ATPase, when it's phosphorylated, you can see a small negative right next to it, which means that when it is phosphorylated, it is inhibited. Okay, so to sum up, we said that the protein kinase A that has been activated due to the increase of concentration in the cyclic AMP in the cytoplasm. This protein kinase A is going to phosphorylate the L-type voltage-gated calcium channel, which is going to lead to the activation of it and inward influx of calcium. and there is going to be phosphorylation of the phospholambin or the calcium ATPase, leading to inhibition of it, which means that the calcium inside the cytoplasm is going to stay in the cytoplasm and it is not going to be pumped to the sarcoplasmic reticulum. Okay, now so the intracellular calcium has increased, and this is going to give a positive ionotropy. Now, what are these drugs that can actually activate the beta 1 receptor? We have the Dobutamine. The Dobutamine is given IV, and it is given for the acute heart failure or the cardiogenic or septic shocks. Okay, the Dobutamine, so when we say that it is IV, this means that it is going to function in a very fast manner, meaning that we use it for the acute cases. And it is going to lead to positive ionotropy, but it is not going to cause any tachycardia. Okay, now the second one is going to be the Dopamine. Dopamine is also given IV. And if you remember from Pharmacology 1, the dopamine has a high selectivity to the dopamine 1 receptor. So the activation of the dopamine 1 receptor, which is present highly in the renal artery, is going to increase the renal circulation. Okay, so the renal perfusion, renal vasodilation is going to happen, which means that if the patient was in a cardiogenic shock and we have given this patient dopamine, we're going to help him so much to save his kidney, because we're going to increase the perfusion to it, although the pumping function of the heart isn't that good. Okay? Now, the third beta 1 receptor agonist is the Ibopamine. Ibopamine can be given orally. I don't think that there is something special about it, and I don't even think that it is used that much. The other one is the Dopexamine. Dopexamine is given orally too, but it actually functions more as a peripheral vasodilator more than acting on the heart. Okay, so I don't know like how much it's used actually. The last one is the Xamoterol. Xamoterol is a special one since it is not an agonist, but it is a partial agonist. Now, what is the importance of a drug being partial agonist? So, partial agonists of the adrenergic receptors are used for elderly, okay? Because their hearts aren't that healthy. They aren't like young people hearts, right? Because they are like kind of old, yeah? So when the heart is aging, we can't use just the adrenergic agonists that we use for young people too, because their hearts aren't going to be that strong to handle them, right? So we can use the Xamoterol as a beta 1 receptor partial agonist for elderly. Now, let's see the third category of the positive inotropic drugs. This is going to be the phosphodiesterase inhibitors. Now, what is the phosphodiesterase enzyme? So as you see here, that the cyclic AMP that is going to be accumulating in the cytoplasm is going to be broken down by an enzyme called the phosphodiesterase. Okay? It is going to be broken down by an enzyme called phosphodiesterase. So this phosphodiesterase is going to convert the cyclic AMP into AMP. AMP is not functioning, right? It is not going to lead to the activation of the protein kinase A. So we can say that the phosphodiesterase enzyme is the enzyme that is terminating the function of the cyclic AMP. Now, what happens if we inhibit this phosphodiesterase enzyme? This means that the cyclic AMP is going to stay in the cytoplasm, and if it stays in the cytoplasm, then the pKa is going to still be functioning, right? And the intracellular calcium is going to be still increasing, and that's what we want. So the phosphodiesterase inhibitors is this group of drugs that is going to inhibit this enzyme. It is only used for the acute cases in an IV form and maximally for 2 days. Okay, we shouldn't use it for so long. And if you would like to know what subtype of phosphodiesterase, it is phosphodiesterase enzyme number 3. Okay, now what drugs do we have in this category? We have the Theophylline and Aminophylline. I don't know, maybe you know that these guys are derivatives of the methylxanthin. Okay, the Theophylline and Aminophylline, I think they are the most used drugs out of this category. Then we have the Amrinone. Now the Amrinone has a special side effect, which is the thrombocytopenia, and it may lead to myocardial hypoxia, and it can lead to tachyarrhythmia. So it is not so favorable, right? The other guy, which is so similar to Amrinone, it is the Milrinone, but it is much more effective. It is actually 20 times more effective than the Amrinone, and it wouldn't cause any arrhythmia. And I don't think that it causes thrombocytopenia either. Anyway, in this category, we have also two drugs, the Enoximon and the Piroximon. These are the least important in this category since these drugs aren't yet used. They are still being tested and stuff, but I don't think they are going to be used because of their pro-arrhythmogenic function, which means that they cause arrhythmia so much. Okay? Now, moving to the fourth category, this is going to be the calcium sensitizers. Now, the calcium sensitizers are the drugs that are going to bind to the troponin C. As you remember from physiology and maybe from my first video, that in the mechanism of contraction of the cardiac muscle, we said that the calcium that is going to be inside the cytoplasm is going to bind to the troponin C, and that's how the contraction starts, right? So, if we increase the sensitivity of the troponin C to the calcium, this means that we're going to increase the contraction of the cardiac muscle by increasing the calcium sensitivity. But did we increase the intracellular calcium levels in this case? No, we didn't. We were just increasing the calcium sensitivity, which means that these drugs would be really, really safe since we're not going to change anything of the physiological concentrations inside the cell. So it is not going to be arrhythmic or arrhythmogenic, and it is energy saving, right? So it is going to end up causing positive ionotropy. In this category, we have two easy drugs, the Pimobendane and the Levosimendane. Now, the Pimobendane has an additional function. Other than being a calcium sensitizer, it is also a phosphodiesterase inhibitor. But the not good thing about it, that it has a very narrow therapeutic range, which means, we don't actually use it that much. The other one is the Levosimendane. And the Levosimendane, besides being a calcium sensitizer, it is also an activator of the ATP-dependent potassium channel. Now, this channel in veins is going to lead to the venodilation. So it is going to help decreasing the preload on the heart. Okay? I think that's all about the congestive heart failure drugs. I hope you guys have enjoyed this video. Please leave a review whether you like this video or, the way that we have given this video comparing to the previous ones. And see you in the next.